Thanks for coming in. I'm Crystal with Hemostasis, and we have a great talk for you guys this morning by Dr. Melissa Berger. She's one of our anesthesiologists here in Florida, and she is an expert in blood management, and she's going to give you a talk on the Clot Thickens. So I'll hand it over to her.
Hey guys, pleasure to be here. Thank you. Let's see if I can advance these slides here. All right, so cardiac surgery, y'all use probably the most blood of any group in the hospital. The amount of blood used overall, y'all use 25% of all the blood products that are getting pumped out by the blood bank. I'm sure you're aware that transfusion of even one blood product results in increased postoperative morbidity and mortality. So our goal really needs to be to minimize the amount of blood products that we're pouring into patients. Viscoelastic testing is now pretty widely recommended by multiple different guidelines, but the reality is that very few centers actually use it. Most people don't efficiently use laboratory-based viscoelastic testing, and even fewer places actually have a point-of-care viscoelastic testing in the operating room where you as the perfusionist can just step to the side, run your test, get your results, and then immediately make some decisions based on what you see. It's usually a process of send the blood, get an anesthesia tech to transport it to the lab, it sits around on the lab shelf for a while. The lab tech finally finishes whatever they're busy doing, brings it to the machine, puts it on, and eventually the result gets loaded into the computer, and then you have to call and find out, hey, is my sample back yet? And finally you get your result, right? So we're trying to speed up that process with what we're doing here. The other problem with transfusion guidelines is there's not a lot of really specific guidelines on what threshold we should be using to transfuse which blood component and what quantity. And as I was just saying, one of the big problems is that when they call it point of care viscoelastic testing, it's often not genuinely point of care. So we did some digging through the literature, and the average processing time of a TEG 5000 was 77 minutes. I'll show you later our data, we pretty much duplicated that. It was taking around 78 minutes at our institution, so that matched. And so when you're waiting over an hour to get back lab tests, well, the surgeons are not real patients, I'm sure you've noticed. They don't want to wait around for an hour when they're trying to get hemostasis and get the chest closed, so we need to do something a little quicker. Enter Hemostasis. They have developed a product here called a Quantra machine, which can actually sit in the operating room. And you as the perfusionist can simply turn around, stick the little blood sample into the cartridge, pop it into the machine, and within about 10 to 15 minutes, get your results. This thing uses sonic estimation of elasticity via resonance, or SEER, sonorimetry, which is an ultrasound-based technology. And so it directly measures the shear modulus of whole blood during coagulation. So it's basically listening to the ultrasound, listening to the music of clotting. So when you start out coagulating blood, you're moving from a liquid over to a solid state. And elasticity is the ability to resist deformation under physical shear forces. So the shear modulus or modulus of rigidity is literally just measuring, is the clot kind of goopy and thin and not going to hold and the chest is going to keep bleeding, or is the clot stiffening up and becoming thick? So as the blood clots gets thicker and thicker due to the formation of the platelet and the fibrin mesh network forming together. So basically this machine will send out little ultrasound waves to a clot as it's forming in the tube. It uses an activator in the cartridge to start clot formation, and then it starts to measure that clot thickening up. So here it is, the ultrasound vibrating the clot. You hear the sound as the clot thickens. It'll start to measure more and more. You can jam out as you're getting your machine ready. So there's now 2 cartridges that are approved. The one we use in cardiac surgery is the Q+. basically because it has a heparin neutralizer, so you can run it while you're still heparinized on bypass and get your results, and then start planning ahead of time what you're going to do about the underlying coagulopathy. And then there's also one called the Q-Stat cartridge, which is approved for liver and trauma surgery. And that one includes parameters to measure hyperfibrinolysis. There is probably some utility for that one in cardiac surgery, because we've all seen the occasional patient that goes into DIC and does have hyperfibrinolysis. So here we go, channel 1, there's a Kalin activator. It's going to activate the intrinsic pathway. Anyone have bad memories of this pathway from their training days? Channel 2 is the Kalin activator plus heparinase. So as I said, it's going to remove the effective heparin, so you can run this thing while you're still on bypass and get results. Channel 3 is a tissue activator plus a heparin neutralizer that activates the extrinsic pathway. So you're going to be basically measuring clot stiffness. Is this clot thin and goopy and not going to hold, or is it stiffening up? There's the extrinsic pathway. Again, nightmares from training. And then channel 4 is a tissue activator plus a heparin neutralizer plus abscissumab, which is going to inhibit platelets. So when you're looking at the clot, you've got both the fibrin mesh network and then all the little platelets in there holding the clot together. And so if you remove the effect of the platelets, you can measure what is remaining, which is largely the contribution of fibrinogen. The channel also contains a TXA acid as a control to inhibit fibrinolysis, and it's used to compare with a channel that doesn't inhibit that lysis. So they'll give you an output called clot stability to lysis, which is the amount of stability remaining after the presence of lysis has been considered. So on this Q-Stat one, this is more for the liver or whatever, where you're trying to look at hyperfibrinolysis. As soon as it starts to detect an abnormal amount of clot lysis, it'll tell you right away. And so it will immediately give you that result faster than having to wait for some of the other where it measures it lysis only at like 30 minutes or 60 minutes definitionally. So you'll get your result as soon as you can using the Q-Stat cartridge. There's various channels that you can see. So let me show you the readout on this. It's very user-friendly, which if you're in a place that trains students, or I train residents, it's easy for them to look at this output and read it. So you've got the clotting time. That's just like how many seconds does it take for the clot to form. It's kind of like an ACT. Clot time with heparinase. So we're removing the effective heparin. So again, you can run this while you're still on bypass and get your results. And then it looks like the clot time ratio. So it measures the ratio of the clot time with the clotting time over the clotting time with heparinase. And that ratio should be 1-to-1 if you've completely reversed all your heparin. If you still have some heparin present in the clotting time, that number will become larger. And so anything above 1.4, we say there's still some heparin effect present, and you may wish to give more protamine. Here's the channel that measures the clot stiffness, or CS, so you can measure how well is your clot going to hold. The PCS, PCS is the platelet contribution to clot stiffness, and then the fibrinogen contribution to clot stiffness. And the big advantage here is that with some of the standard vet, and by that I'm meaning like thromboelastography, thromboelastometry, you don't necessarily get a true separation of when you're looking at that alpha angle and the MA, what portion of that is truly platelets and what portion of that is fibrinogen. So this is able to separate out those components a little bit better. And then on the Q-Stat cartridge, as I said, there's the clot stability to lysis measurement that's going to measure as soon as it's detecting abnormal amount of clot lysis, it will tell you that there's some hyperfibrinolysis going on. Clot times and clot stiffness are measured from the evolving shear modulus. It'll give you the curve as it's starting to measure. So if you're used to looking at a tag or something, you can still get that little wine glass shape that you're used to looking at. So let's take a case from real life of how one might use this in the operating room. So here's a 62-year-old guy. He comes in as an emergent transfer for an acute type 1 aortic dissection. He's taken directly to the OR. They do an ascending aorta hemiarch replacement with a zone 2 debranching under deep hypothermic circulatory arrest, the valve-sparing aortic root construction. We call that the Florida sleeve. It was invented by one of our surgeons at UF. Left atrial appendage clip and a PFO closure. So our plan with the Quantra is we're going to initially obtain a baseline because we know that patients coming into the OR with dissections and aneurysms often have underlying coagulopathy. So it's nice to see how bad are we starting off here. Then we're going to evaluate the coagulopathy just prior to coming off bypass. And then after we've got our results, we can decide whether we're going to give platelets, cryo, PCC, fibrinogen concentrate, whatever. And then we can repeat the Quantra afterward to see how well we've done in terms of correcting those abnormal values. So this was our baseline. You can see here that clotting time was normal, so that's good. We're not heparinized yet, so the clotting time with heparinase is essentially the same, giving us a ratio of 1.1, so there's no heparin effect because we haven't given heparin. Looking at the clot stiffness, it's a little on the low end, but it's still within that normal range. Same thing, the platelet contribution still appears normal, and the fibrinogen contribution, it's right on the edge, low normal, but it's still hanging in there. So we're okay for now. We'll see. So here is our Quantra on bypass. So we've done the case, you've now walked over, you've stuck your cartridge in, gotten your results, and here's what you see. There's no clot detected, and that's expected because you're heparinized. When you look over here with the heparinase channel, you do see that, okay, underneath the clotting time without heparin effect is kind of up on that higher limit of normal here. The ratio is not computable. Again, we're heparinized. This is an expected result. And then we come to the clot strength. The clot strength is almost 0. That's great. It's going to be a long night. So then we look at what is the platelet contribution to clot strength. Really, really, really low. Not good. And how about the fibrinogen contribution to clot strength? Also sucks royally. So we're now looking at this, okay, I need to go ahead and call the blood bank and get some platelets ready, get my fibrinogen concentrate mixed up, or get some cryo brought into the room, whatever it is we're going to use. We now know specifically what it is. And this is really so much better than being like, okay, we're coming off bypass, let's just start putting in blood products and hoping we correct the coagulopathy before the surgeon freaks out because he can't seem to get hemostasis. So like I said, so we had the decreased clot strength due to platelet and fibrinogen deficiency. So we got 2 units of platelets and 2 units of cryo in this case. And so here's our repeat after the transfusion to see how well we did. We see that our clotting time is still within the normal range. That's good. We've now reversed with protamine. So our clot time with heparinase is essentially the same as our clot time. It's like an ACT, as I said. And our ratio is 1, so it's not over 1.4. I don't need to give more protamine, which is, again, really valuable because, as y'all know, giving more and more protamine can actually start to cause coagulopathy the more and more you give. It's really hard to find that sweet spot where you reverse the heparin but not overdose the protamine. And then let's see how we did. Well, our clot strength is better. That's good. When we come over to our platelet contribution to clot strength, we see that we've corrected it, so we're now within the normal range on platelets. And then when we look at our fibrinogen contribution to clot strength, again, we're back into normal range. So there's our post-transfusion one. But the surgeon says, the patient is still oozing. Please, can you help me out here, guys? So I looked back at this and looking at the clotting time, it was still a little on the higher end. It was normal, but on the higher end of normal. So I decided to go ahead and give some PCC. And that finally got the chest to dry up where we could actually get out of there. So we're going to look briefly at some of the data, looking at the Quantra system versus the other available options. So first we're going to look at the data on the Quantra system versus standard lab testing. So the Quantra Q Plus, it shows really good correlation to standard lab testing. Sorry if I messed up the thing. All right, sorry about that. So when you look at the data coming from the Quantra device, you can actually correlate it very well to the standard lab testing in terms of testing fibrinogen levels, platelet counts, and you can predict the threshold for fibrinogen and platelet transfusions. it's actually quite a nice linear correlation. We've actually at our institution, we've developed an algorithm where we look at what you would usually use is like your cutoffs for platelets. Say you want a platelet count above 50, or you want it to be over 100, or you want it to a fibrinogen level of 100 or 200. You can correlate that to a Quantra value and then decide how much platelets or fibrinogen you're going to be giving based on that. This was Barishnikova and al. Sounds like a ballerina. Looking at comparing the Quantra device to standard lab testing. And you can see there's a very nice linear relation. You've got the fibrinogen level there, the platelet count, and there's a nice linear correlation between the two. So how does it compare to other viscoelastic testing? Let's size it up against the competition. So this was Deanna and al. It was a prospective observational study where they were looking at the Quantra Q Plus system versus thromboelastography, or TEGs. You can see that there's actually pretty good correlation between the clotting time and the TEG-R time. So that's looking at your coagulation factors that would be corrected with something like PCC or FFP. Decent correlation between clot strength and the TEG-G. There's also a correlation between the fibrinogen contribution to clot strength and the TEG-G. So there's decent correlation. It's not a perfect one-to-one. The parameters are not interchangeable by any stretch, but there is correlation. And it makes sense. We're all measuring the same thing, which is how is a clot forming. Comparing it to ROTEM, this was a study by Balog et al. Comparing it. And again, here it showed a strong correlation between the ROTEM sigma for determining clot times and clot stiffness and the parameters to assess clot development. The parameters, again, are not totally interchangeable, though. The other thing of note here was that the median time to first and complete results was much shorter with the Quantra device. So it was only 6 minutes to get your initial time. You're looking at that developing clot before it starts to take off in the clot form. That was your initial clot. That takes about 6.8 minutes in this study. And then by 10.9 minutes, they had completed getting the result with the Quantra. Compared to with the ROTEM sigma, the first time you even got data was 13.9 minutes. So the Quantra had finished by the time the ROTEM was actually even giving you your first little bit of information as the clot was going. And then it took another 10 minutes or so, up to 21.5 minutes before it actually finished and gave you your final result. So there's a big savings in terms of time with the Quantra device, which is why we ended up going with it at University of Florida. And then looking at the versus some of the newer generation testing devices, because they've now come out with the TEG6S, the ROTEM sigma. The Quantra and the ROTEM showed strong signal correlation to platelet count and contribution to clot strength, while the TEG6S has a little bit lower. Same thing with the fibrinogen level. Strongest with the Quantra, a little bit weaker with the ROTEM sigma, and then weakest with the TEG6S in this study. So then we're going to go into some of the stuff we did at University of Florida, where we compared the Quantra system in practice versus standard lab testing. Sorry, this is not University of Florida. This was with Tibby et al. First. I'll give you our UF data in a second. So they looked retrospectively at patients. Half of them they were doing the cardiac cases using the Quantra device, and the other half they were using standard lab testing. So they're sending a PTT, a PTINR, a fibrinogen, a platelet count. And when they just put the Quantra device into practice, this was what they found. They were able to really dramatically decrease the amount of blood products they were giving. There was a huge drop off in FFP use. You can see that bar where there's a big blue bar that was FFP before, and then coming down to after, like almost no FFP use afterwards. They were able to get a little decrease in their use of red cells, a decrease in their platelets, and a decrease in the use of cryoprecipitate. And even for the ones that aren't large, like say the decrease in red cells, as we said before, even giving one additional red cell to a patient who continues to bleed because you haven't corrected the coagulopathy, every additional blood product you give, that's more and more morbidity and risk of mortality that you're giving to that patient. This was Zlotnick and al. A single city study before and after the University Center. Similar thing, they had 66 patients they did with the Quantra, and then 117 they did with standard lab testing. they had similar results. They were able to decrease their red cell transfusions from 78% down to 64%. FFP went down significantly by half, from 85 to 41%. And then platelet transfusions, they cut way back from 82% down to 55%. And it should be mentioned that all of these were done with no increase in patient bad adverse events or outcomes. They used exclusively fibrinogen concentrate. They didn't have any change in the proportion of patients getting that in their study. I think this was done in Europe, where they don't have cryo. And then the incidence of major perioperative bleeding was reduced in this group. So 56% had major perioperative bleeding afterwards. They cut that down to 36%. Once they were able to get a device in the room that gave them really fast results, they were able to make data-driven decisions and rapidly correct the coagulopathy in the OR before they ever left to go to the ICU. They had things under control, and the patients did better afterward. So then we're going to come to some of the stuff I've worked on at University of Florida. This is putting the Quantra system in practice versus what happens when you have viscoelastic testing in the laboratory. So we're kind of comparing the highest standard of care in the lab to the Quantra device in the OR. So initially we took 77 adult patients that were undergoing either elective or urgent surgery. We put these Quantra devices in all the ORs, and then we also obtained lab-based TEG 5000 data for all the cases. Here's our initial results. So the Quantra device, we got our result finished up in 12.9 minutes. It only took 24 minutes with the TEG 6S. And then when you look at the TEG 5000 with heparinase, 83 minutes before we got a result back for the lab. And just look at the times here. So from the time we collected it and the anesthesia tech came into the room, got the tube, ran it over to the lab, that's between 9 to 11 minutes. And then the time to receiving the tube in the lab to actually getting a result, between 70 to 74 minutes. Like, it's ridiculous. What am I going to do for an hour waiting for these results to come back? And that was the struggle we were facing. Was what we did do is we were just sitting there kind of eyeballing things and using clinical judgment, or you might open up the TEG manager and try to follow the developing little wine glass formation and try to guess where you thought the lines were heading. And that's just not the way to do medicine these days. And this is just a comparison to the Rotem Sigma. By comparison, the Quantra finishes results around 13.9 minutes. The Rotem Sigma finishes around 21.5 in this particular study, just to compare between TEG 6S, Quantra, the TEG 5000. We were only comparing the TEG 6S and the Quantra in our institution. So we had actually placed the TEG 6S in the OR with the Quantra, and then we were comparing it to the TEG 5000 in the lab. So Quantra beat it out beat all the competition in terms of how many minutes it took to get our results. So that was kind of a big selling point for us, which is why we ended up instituting it at University of Florida. So then we looked further into what happened once we actually put the Quantras in our cardiac ORs and just started using them full time on a regular basis. And I looked back over the first 6 months after we had introduced it. And then for control, I looked back at the prior year when the TEG 5000 device alone was being used in the lab. We're comparing the number of units of blood that we ordered and then wasted, meaning that it got brought into the room, but they never got given to the patient. And so a lot of those blood products end up getting thrown in the trash because things like cryo and platelets, they don't last very long out of the blood bank. Once they're thawed and delivered, you have to use them within 4 hours. You have to toss them. The red cells can at least be sent back and stuck in the fridge and go to a trauma patient later on in the day. But it still takes, the red cells out of circulation for some period of time that the blood bank doesn't have those available to give to another patient if they're just sitting in our OR. And then we also looked at some secondary outcomes. This was the treatment algorithm that we came up with. And then we looked at the data on the demographics and everything, did all the fancy statistics. Shout out to my statistician, Dr. Garvin. She's awesome. So initially, there's no major differences between the groups in terms of their patient characteristics, baseline lab values. They all started around the same pre-op hemoglobin level. They all had about the same perioperative anticoagulant use, types of surgery, as far as was a big aorta surgery, cabbage, valve, whatever, were similar between the two groups, no statistical differences. And then here's our results. This is our decrease in transfusions. So taken as a whole, all blood components decreased from 53% down to 54%. There was a dramatic reduction in FFP use by 95%. I don't know why we were giving so much FFP, but for some reason when we had the data there and we're just like running in red cells, matching it up with an FFP, waiting for the coagulopathy to correct, we were able to really reduce that amount dramatically. And just of note, there was no increase in our PCC use. So it wasn't like we switched from using the FFP and just started using a lot more PCC. There was actually a decrease in our factor 7 use when we looked at the data. So we were actually using data-driven decisions to decide what to give and not truly wasting a bunch of unnecessary blood products going into a patient that they didn't need. Then we had our secondary effects here. So looking at our red cell use, we decreased our red cell transfusions by 24%. And of note, we didn't have any differences in our cell salvage, our autologous normal volemic hemodilution use. We were doing it the same way in both groups of patients. They all had the same baseline hemoglobin. So it was as matched as you could get. But when we had rapid data and we're able to get the bleeding under control more rapidly, we were able to drop the need for additional transfusion because we weren't sitting there with the chest open and oozing for an additional, hour or whatever. And then I think I mentioned the cryo came down a little bit, not by a lot. And then in terms of inappropriate ordering and waste, it turns out when you have data, you can actually use it to make a decision and you don't have to just order a bunch of stuff and start giving it. So in terms of reducing the underutilization of all blood components compared to laboratory-based TEG, we way reduced the waste. So we had a decrease of 76% reduction in the waste of platelets, 79% reduction of FFP, red cells, 77% reduction, cryo, 90% reduction. So we weren't ordering a bunch of units in ahead of time, having them all hang out there, and then kind of giving as needed until the bleeding stopped. We were able to see what we needed, order specifically what we needed, and give those products and not have a lot of stuff we were sending back to the blood bank or dropping in the trash at the end of the case. When they look at blood product transfusions, they like to look at a cross-match to transfused ratio for red blood cells. The ideal ratio is that if you are below 2.5, and so the idea is that if you type and cross 2.5 units for that amount, you would actually give one to the patient, and that's considered to be a decent ratio. Ideally, you'd have a ratio of 1, right? If you only ordered one blood product and gave every blood product that you ordered, the ratio would be 1. So our initial ratio was 3, so for every 3 units of blood we were ordering, only 1 was making it into the patient. We were able to cut that down to half. So for every 1.5 units of blood we're ordering, we were actually transfusing it. So we got pretty close to 1. We're a little over, but not bad. We kind of did a similar ratio to look at the order to transfused ratio for all blood products. We're able to reduce that from 2.5. So for every 2.5 units of blood products in general we were using, only 1 made it into the patient. And then we got that down to 1.26, so almost that perfect 1-to-1 ratio of us being able to use very rapidly available specific data to determine what we needed to order and give to the patient. So ordering more closely matched use after introducing the Quantra. There's also a big association, and this is not news breaking data, but no kidding, when you transfuse less, you have less mortality. And I gotta say though, we all know this, but when I was doing the data analysis, I had to open up each chart and I'm looking at, okay, here's Mrs. Smith, here's Mr. Jones, ooh, he didn't make it. And you look at each individual chart and you realize, yeah, when I give a transfusion, I'm very directly impacting the patient in front of me on the table there in terms of their chance of making it out of the hospital or having a good life for the next year or so. So here you can see in the group that was transfused versus not transfused, there had an odds of mortality prior to discharge 2.5 times higher, and then their 30-day mortality was 3.5 times higher if they had received a transfusion versus not. So our study very clearly demonstrated the benefit of the Quantra system. We were able to remove a lot of the time delays involved in the transport of specimens and laboratory processing. We are able to show that timely, accessible point of care located in the operating room contributed to improved outcomes. So Quantra is the most musical. It uses ultrasound. So in summary, with the Quantra implementation, overall transfusion requirements were reduced, notably of FFP, with no compensatory increase in our PCC use, and actually decrease in factor 7 use. Our red cell transfusions were reduced with no increase in cell salvage or ANH. And with the Quantra implementation, we reduced our inappropriate ordering and waste. The C/T ratio of the red blood cells was reduced from 3 to 1.49, and our overall blood product ratio for ordered and transfused was reduced from 2.51 down to 1.26, indicating that ordering actually matched use. So y'all need to go get yourself a Quantra and have a good rest of your conference.
Good morning, and thank you. That was excellent. I do have one question.
Yeah.
How do you train or how do you educate the physicians, even though your device says only do this, they resort back to what they've always done that works. And so it kind of feels like with a couple of our physicians, having the device doesn't better our outcomes because they're always given 4, 2, and 2. So how do we get them to buy into the device and what it's saying and to give it a chance?
Yeah, so we have 4 red cells and 4 FFP at the beginning of the case, regardless. And that was a big cultural change we had to have. What we did was we developed a committee where we had representatives from perfusion, from pharmacy, from anesthesiology, and then from surgery. And initially we had some educational meetings where we just went through the data. And we invited everyone in all those departments to come and discuss it. And then for every meeting we had, the clever way we did is we put every surgeon name on the email, and as well as like perfusion and pharmacy and blood bank and anyone that might have an objection to what we were doing, basically. We put their names on there, and we included them in the Zoom meetings for it, so they had, easy, we tried to do it at times so that everyone could come to the meetings. And then when we made a decision as far as what algorithm we were going to follow, they were all CC'd on the email, and they were invited to give us questions or concerns or any pushback that they wanted to do. So by the time we had all agreed upon our algorithm, we were like, okay, guys, this is what we're doing. We've agreed on this. You can't give us pushback. And you had a chance. You were invited to the meetings. You were on every email. You had every opportunity to grumble and complain about it if you didn't like it or wanted to do it however you were trained. And I totally agree that it's a big sort of cultural problem. It's like, well, I trained that way. It's always worked for me. I don't know why I'd do anything different. But the data really suggests that there's better ways of doing this stuff and that we should be following evidence-based medicine. So because we kind of laid all that groundwork, by the time we're actually in the operating room and the surgeons are griping for something, we could show them and say, well, this is the data. It's not just my opinion. This is the data from the machine and the algorithm we've agreed on. So this is what we're doing. And that enabled us to really come together more as a team and not be at odds with each other trying to make the surgeons happy. Because I very much sympathize with the problem that you're bringing up.
Hi, Greg from Boston. Thank you very much for that wonderful presentation. I actually had an opportunity to visit the University of Florida a few months ago on the pediatric side, and I was very impressed with what I saw. The question that I have, and we use, in pediatrics, we use TAG 6S in the operating room, and I think it has helped our practice. My question for you is regarding red blood cell transfusions, because a lot of professions, whether anesthesia, perfusion, surgery, we reference these ICU articles, OR articles about RBC transfusions and as it relates to morbidity and mortality. And I was wondering, since you know so much about this, are you aware of any data, published data that looks at risk profiles for different RBCs? So I look at RBCs from the blood bank as one risk profile. Those that are washed in a cell saver before transfusion, that's different. Then, of course, in pediatrics, we can do things like pre-bypass ultrafiltration. Are you aware of any stratification of red cell risk profiles due to how that product is treated before it gets to a patient?
So there is a lot of research done on the age of the red cells. And in theory, the longer a bag of blood sits around on the shelf, the more those red cells break down. So by the time it's been sitting there a while, you're giving, frankly, a lot of dead red cells, which is ultimately a lot of free hemoglobin, which is going to mess with the kidneys, et cetera. There's the breakdown products, so they're, more potassium, et cetera. The data that exists, and I think the more recent one was like 2 or 3 years ago in the New England Journal of Medicine published it, looking at the quality of red cells. They came up with the conclusion that there wasn't a statistically significant difference between the age of the red cells. Do most of us truly believe that? No, because if I said, hey, I'm going to give you a bag of blood, here's this 30-day-old one, and here's one we just got 2 hours ago, what would you want, right? I mean, I know what I would pick. Yeah. But the data, at least so far, has not been able to show a big difference between that. So for that reason, pharmacy or blood bank won't stratify blood products necessarily, and so I'm not aware of any studies that's risk stratified the patients other than the ones looking at the age of the red cells.
Thank you very much. We have about 1,000 participants, so hopefully someone out there will be interested enough to do a study looking at red blood cells directly from the blood bank versus that washed in a cell saver or treated in some other way. Thank you.
Yeah, absolutely.
Thank you. There's also some questions from the online audience.
Okay.
I'll combine them. So one person was asking if you have a clot time ratio that is above 1.4. Is the answer always protamine, or are there other causes? And then the second question was, does the Quantra give you a quantifiable number that makes you say, like, I have to give that many platelets, or I have to give that many cryo to a patient that has a certain number, or is that more like an experience-based thing?
Yeah, so for the first question, it was, did the clot time ratio always tell you need more protamine, or could it ever be off? So if your clot, so it's the clotting time over the clotting time with heparinase is what you're measuring. So if your clotting time starting off is already way off, I don't know, I guess the ratio is still going to stay the same because you're still going to measure the underlying coagulopathy. So it should truly be, if it's over 1.4, it's measuring just the heparin effect on that ratio, and you could determine to give protamine, because the ratio of coagulopathy over coagulopathy should still cancel each other out, and you're left with just the heparin effect. So it should tell you truly, do I just need protamine? And then the other question was, okay, so I have some number on, let's say, my platelet contribution. Can I figure out exactly how many units of platelets I need to give based on that number? Our medical director for Hemostasis, which used to be my mentor at UF, Dr. Bruce Spies, if that person wants to send me an email, I'll be happy to answer that for them. He's actually worked out his ratio, and I want to say it's something like 0.75 times the number is equal to he has a way to cc's of platelets to give. He actually has worked that out based on a lot of prior literature done looking at it. But if they want to shoot me an email, I'd be happy to answer it for them. My email is mburger@ufl.edu. So it's like universityoflorida.edu. And then my name, Melissa, M, and then burger, B-U-R-G-E-R, like a hamburger. So shoot me an email, and I'll be happy to get that answer for you exactly.
Any more questions from the audience? I have some online questions still. So an online question is, do you use this to manage ECMO patients in the ICU?
In our ICUs, for our VA ECMO, we predominantly use heparin, and so you can use it. We have not used it in the ICU. We've tried to get it introduced into the ICU, mostly for just managing coagulopathy after a cardiopulmonary bypass when they come to the unit. It definitely could be used to manage coagulation. What I have done is, we didn't have one actually in the ICU, but I've definitely taken samples from ECMO patients and run them down to the operating room and then run it to see what kind of coagulopathy the ECMO patients may have. Now, if you have a patient on bivalirudin, that effect is not canceled out by any portion of the Quantra device. We don't know of an inhibitor. I'm sure someone in the company is working on that in some of their research somewhere, but for the moment, we don't have a way to look at coagulopathy underneath bivalirudin. So you would not be able to use it, particularly like on our VV ECMO patients, we predominantly use bival, and so we couldn't really use it for those patients. So if you're using a heparinized patient on ECMO, yes, you could use it. Realistically, the company's not going to like me saying this, but realistically, it's probably a little expensive to be running like hourly ACTs or clot times using it. But definitely, I think it's great for spot checking throughout the day, or when you end up on these long-term ECMO patients that are just oozing from every orifice and cannula site and IV stick, knowing what their coagulopathy is and how to correct it, especially if you need to now take them back to the OR, is very helpful to have a Quantra device in there.
We also have questions, and that's more like technical, about what the footprint is in the OR and what the quality controls are needed for. I don't know if the company wants to answer that, or you.
I feel like I had one picture. I used to know the exact specification. So it's about this big. Do you know the exact measurements, Crystal? About this tall. Oh, the quality. So it does its own internal self-check. Every morning when you turn it on, it'll do its automatic check. So it's not like those darn ACT machines that are going to start doing their quality check right in the middle of your case when you really didn't need them to delay getting your ACT. So the internal check is done every single morning when you turn on the machine. And then there is some level of maintenance that has to be, done over the years that you have it, just to make sure it's working right. I'll just say my experience is that anytime I've had an issue with it, I just text or call the rep and they come right over and help us with anything. And then it's usually the core lab will maintain some responsibility in terms of just monitoring the off-site locations of devices and making sure people are trained properly to use them and credentialed. You just basically swipe your badge to be able to use it as the user. Swipe your badge, swipe the patient's ID number, and then you can, put on your tube and your cartridge and get it going.
Yep. So the analyzer does require a wet QC, if everybody's familiar with that. And usually labs will develop a quality control plan that allows them to do a wet QC once every 30 days. So.
Do y'all have it set up in the vendor booth over there?
We do.
So if you want to see, if you're here physically present, not online, and you want to see the device, you can go over to their vendor area and see. It's a pretty compact little device that doesn't really take up a lot of space. And then you can certainly go on the website, which is just hemostasis.com, and it gives you the exact measurements of the device if you want to see, will it fit in your space in the operating room.
And then we have another question online. Do you use it for all your patients, or just the ones that you're like, oh, this patient is risky, or this is a long operation, aortic surgery? What kind of patient population do you use it for?
We've been using it for all of the cardiac surgery patients. And then I don't really do these areas, but it's now expanding to be used in the trauma hall. As patients come in to the trauma hall, they should be getting a baseline Quantra to see what their coagulopathy is, if any. It's being used in liver transplant. I think there's a lot of potential for it to be used in some of the major ortho cases. The peds cardiac area is one that it's not made a ton of headway into yet that I think has great potential. The area of OB, they're starting to work out some of the normal parameters for a pregnant patient, because as you know, in pregnancy, there's a change in the amount of fibrinogen and platelets and all that is be considered normal in the state of pregnancy. And so they're working out what the parameters should be for that population. So it's expanding in its use. But as far as just cardiac surgery goes, yeah, all of our patients get a baseline Quantra. They get one when we're getting ready to come off bypass before heparin has been reversed. That tells us what products we're going to order to reverse coagulopathy. And then after I've given all those products, we'll check one afterward to see if we're back to baseline on all the parameters or if I still need to give something else to get coagulopathy completely corrected. And, if it's completely normal and you're bleeding, you got to tell the surgeon, can you look behind that aortic anastomosis again, or maybe check your coronaries there, because something may be surgically bleeding if the Quantra is stone cold normal and there's still quite a bit of blood in the field.
Okay. Well, thank you for Hemosonics. Thank you, Dr. Berger, for your contribution. And we'll have a very short break to get your coffee, and then we'll be back at 8:50. Thank you so much, and don't forget to visit the booth.
Thank you, guys. Shout out to all my perfusionists. Y'all are awesome.